You know, usually when we talk about a medical diagnosis, there's this expectation of like mechanical precision.
Right.
Like you break your arm, the x-ray shows a jagged white line, and the doctor just points at the film and says, there it is, broken or not broken.
Exactly, yeah. That visual proof provides this immediate comfort to both the clinician and the patient. I mean, we are just totally conditioned to trust things we can categorize with a quick scan.
But the moment you step into the world of mental health, I mean, that x-ray machine is entirely useless. The diagnostic landscape gets really murky really fast.
Oh, absolutely. We're forced to rely on observable behavior
Yeah.
and, subjective reporting rather than just a simple blood test, which is just the reality of psychiatric medicine, right? We're mapping this deeply complex, completely invisible landscape.
Yeah, and that murkiness is basically our mission for this deep dive, because today we are unpacking a really fascinating stack of clinical nursing sources all about anxiety disorders.
And we are not just looking at the high-level theoretical psychiatry here either.
Right? No, we are looking at the bedside reality. We want to know how healthcare professionals, specifically nurses, right, how they recognize and respond to the physiological storm of an anxious patient when it's like happening right in front of them in real time.
Because that bedside perspective really strips away all the abstraction. We are looking at the surprisingly contentious history of how the medical field even defined this condition, the very real biology it creates in the body, and exactly how nurses use concepts like cognitive bandwidth to de-escalate a patient who's in severe distress.
All right, let's unpack this, because right off the bat, our clinical sources point out this crucial, highly technical distinction from the DSM-5 that pretty much frames everything else we're going to talk about.
It really does, yeah.
Because in everyday conversation, people use the words fear and anxiety interchangeably all the time. But clinically, they are entirely different biological beasts.
Completely different, yeah.
Fear is the emotional response to a real imminent threat. It's that immediate fight or flight reaction, like you see a bear charging at you in the woods. Your body experiences fear.
Right. Fear is anchored entirely in the present tense. But anxiety is the anticipation of a future threat. So it operates in the future tense.
Oh, that's a good way to put it.
Yeah. So instead of the sudden urge to sprint away from a predator right now, anxiety manifests as like sustained muscle tension, hypervigilance, long-term avoidance behaviors. The body is essentially preparing for a danger that just hasn't arrived yet and, frankly, might never arrive.
And if you're listening and wondering why this distinction matters to you, I mean, just consider the sheer scale of the issue. Whether you are catching up on clinical literature or prepping for a stressful quarterly review at work, or honestly just trying to navigate the modern world, you are going to encounter this physiological cascade at some point.
Definitely. This is not some rare phenomenon locked away in a specialized psychiatric ward.
No, not at all.
The prevalence data underscores that perfectly, actually. According to Ronald Kessler's National Comorbidity Survey replication out of Harvard, anxiety disorders, when you group them together, are literally the single most common category of mental illness in America.
Wow.
Yeah, roughly 1 in 5 adults will meet the diagnostic criteria for an anxiety disorder in any given year.
1 in 5 adults? That is a staggering statistic.
It's massive. Exactly a quarter to a third of all adults will meet the criteria at some point in their lives. And conditions like generalized anxiety disorder and specific phobias present about twice as often in women as in men.
So for a nurse, this dictates that anxiety is this secondary or even primary condition that they'll be managing constantly on every single unit, regardless of why the patient was originally admitted to the hospital.
Exactly.
But to understand how a nurse treats that patient today, we really have to trace the history back, because it took an incredibly long time for the medical field to even agree on what they were looking at.
Oh, centuries.
Yeah. Before 1980, American psychiatry didn't even use anxiety disorders as a plural categorical term.
Right. The timeline reveals this really deep struggle for clarity. So, starting in 1769, you have a Scottish physician named William Cullen, and he coined the term neurosis.
Okay.
But he basically used it as a catch-all classification for disorders of the nervous system, where physicians just couldn't find a clear structural lesion in the body.
So it was just a medical placeholder, like a really fancy way of saying we observe the symptoms, but we don't know the biology yet.
Pretty much, yeah. And then Sigmund Freud attempted to impose some order on that chaos in 1895.
Ah, Freud.
Right. He published this pivotal paper arguing that a very specific cluster of symptoms, chronic apprehension, physical palpitations, sweating, and sudden panic attacks, needed to be officially separated from general neurasthenia, which was the era's term for general nervous exhaustion.
Gotcha.
And Freud called this new unified syndrome anxiety neurosis.
Though we definitely have to acknowledge that Freud's theory about the underlying cause of these symptoms is totally debunked today.
Oh, completely.
Because he hypothesized that anxiety neurosis was the result of dammed up libido, essentially undischarged sexual tension converting itself into physical panic, which, I mean, he was entirely wrong about the mechanism.
Entirely.
But separating that specific cluster of symptoms into a distinct diagnostic category was still a massive structural leap forward for the field.
It was. But what's fascinating here is that the biological validation for that separation didn't actually arrive until the 1960s. And that was thanks to a Columbia psychiatrist named Donald Klein.
Right?
Klein was treating patients with severe panic attacks using a specific tricyclic antidepressant called imipramine. And he observed that the medication completely blocked the sudden, intense panic attacks in his patients.
Which seems like a massive breakthrough just on its own.
It was, but the real breakthrough was actually in the limitation of the drug.
Wait, really? How so?
Well, while imipramine stopped the acute panic attacks dead in their tracks, it did absolutely nothing for the patient's chronic anticipatory worry between those attacks.
Oh, wow.
Yeah, so they were still experiencing this constant low-level dread.
Okay, I love this part of the history because it acts like this perfect diagnostic key. It's like imagine a mechanic trying to fix a malfunctioning car, right?
Okay.
If the mechanic cuts one specific wire and the car's blaring security alarm instantly turns off, but the engine continues to overheat, that proves, beyond a shadow of a doubt, that the alarm system and the engine cooling system run on two completely separate electrical circuits.
Exactly. Klein proved a pharmacological dissociation. If a single chemical molecule turns off one symptom cluster, the panic, but leaves the other symptom cluster, the anticipatory worry, completely untouched, well, they just cannot be the same underlying disease.
Right.
Panic and generalized worry were biologically distinct circuits in the brain.
And that single pharmacological discovery is what dismantled Freud's unified anxiety neurosis, right? It directly led to Robert Spitzer's checklist revolution in the 1980 release of the DSM-3.
Yep. The psychiatric community finally officially split the diagnosis into the distinct categories we use today, recognizing panic disorder as fundamentally different from generalized anxiety disorder.
And because Klein proved these are distinct biological pathways, modern neurobiology has mapped exactly how this physiological storm plays out in the body, which is just fascinating.
It really is. At its core, an anxiety disorder involves a threat detection system running in severe overdrive. So the amygdala, which functions basically as the brain's alarm center, becomes hyperreactive.
Which kicks off this massive systemic chain reaction.
Right, so the amygdala triggers the HPA axis. That's the hypothalamic pituitary adrenal axis.
Okay.
And this is the chemical relay system that communicates with your adrenal glands, flooding your bloodstream with cortisol, the primary stress hormone.
Right.
And simultaneously, a structure in the brainstem called the locus coeruleus, which is essentially the body's norepinephrine factory, dumps excess norepinephrine into your circulation.
And that surge of norepinephrine is what drives the sympathetic cascade. Like, the physical symptoms are unmistakable. You get tachycardia, meaning a dangerously racing heart, diaphoresis, which is just sudden, intense sweating, tremors, dilated pupils, hyperventilation.
Yeah, and all of this acceleration happens while the brain's primary braking system is basically failing.
Oh, right, GABA.
Exactly. Gamma-aminobutyric acid, or GABA, is the neurotransmitter responsible for inhibiting these signals and calming the nervous system down. But during this storm, GABA is functionally underactive.
So the accelerator is pinned to the floor and the brakes have literally been cut.
Exactly.
Which brings us to the everyday reality of this in a hospital setting. Because our sources detail this fascinating presentation of panic disorder in the emergency room. Patients will rush through the doors exhibiting chest pain, a racing heart, severe shortness of breath, and a profound verbalized fear that they are actually dying.
Yes.
And the DSM checklist for a panic attack literally includes fear of dying as an official diagnostic symptom.
It does. And triage nurses and ER physicians operate under a very strict, non-negotiable rule in these scenarios. You never assume the patient is just experiencing anxiety.
Because it's too risky.
Way too risky. A severe panic attack mimics a myocardial infarction, a heart attack symptom for symptom. The objective presentation of a hyperreactive amygdala is basically indistinguishable from the objective presentation of cardiac ischemia.
Okay, but let me push back on that for a second. If the symptoms of a panic attack and a literal heart attack look identical, like the diaphoresis, the chest pain, the elevated heart rate, how can triage staff possibly tell the difference just by visually assessing the patient in the waiting room?
Well, you've hit the nail on the head. They can't.
They just can't.
Visual assessment is entirely insufficient, which is exactly why objective cardiac workups are mandatory. The clinical team must run an EKG and draw blood to check for cardiac enzymes like troponin. The panic attack will peak and naturally resolve within about 10 to 20 minutes without causing actual necrosis or tissue damage to the heart muscle. But the clinical team cannot verify that without the lab results. You always have to rule out the body before you settle on the mind.
And that strict protocol shatters another major misconception that nurses are trained to avoid. You cannot assume that a patient sitting quietly in a chair looking physically calm isn't experiencing severe internal anxiety. The biological storm can be entirely internalized.
Absolutely. And since the physical symptoms can hide or, effectively mimic a lethal cardiac event, nurses require a highly structured way to actually communicate with these patients.
Right, because you have to know how to talk to them.
Exactly. So Hildegard Peplow, who was a huge pioneer in psychiatric nursing, developed this interpersonal theory built around anxiety as a central organizing concept. And she categorized anxiety on a continuum of 4 distinct levels: mild, moderate, severe, and panic.
I love this framework because it ties so beautifully into the Yerkes-Dodson principle, which explains the relationship between arousal and performance.
Yes, it's a perfect overlap.
Right. The concept is that a mild amount of anxiety actually improves your cognitive function. Under Peplow's definition, mild anxiety heightens your environmental alertness and motivates learning. Like if you have exam day jitters, that mild anxiety sharpens your focus directly onto the test paper.
Exactly. Mild anxiety is highly functional. The danger lies in the tipping points along that continuum.
Yeah.
Once a patient crosses into moderate anxiety, you start to observe a narrowing of their perceptual field.
Yeah.
The patient begins to exhibit selective inattention.
Yeah.
They might hear a little less of what the nurse is explaining, filtering out peripheral information.
But when they hit severe or full panic levels, rational thought just collapses entirely.
Completely collapses.
The patient's perceptual field reduces to this incredibly tiny point. They might fixate on a single ticking clock on the wall, completely unable to process the words the medical team is saying. And in full panic, their behavior becomes profoundly disorganized.
Right. The cognitive bandwidth simply ceases to exist.
It's exactly like trying to download a massive 5 GB software update on a smartphone that has 1% battery life and a terrible dropping Wi-Fi connection. The system is technically powered on, but the bandwidth is completely gone. You cannot force complex data through a compromised connection.
That is a great analogy. And when the system is at 1%, the nursing intervention must fundamentally change. At the mild or moderate levels, a nurse can effectively use therapeutic communication. They can hand a patient a pamphlet and teach them about the potential side effects of a new medication.
Sure.
But when a patient escalates to severe or panic levels, teaching is immediately abandoned. You do not attempt to explain complex discharge instructions to a patient who has lost their cognitive bandwidth.
Right, the priority shifts from education to immediate safety and stabilization. The nurse literally stops trying to push the download and focuses on plugging the phone into a power source.
Exactly. You reduce the stimuli in the room, you dim the lights, you maintain a calm, steady physical presence, you lower the pitch of your voice, and you issue incredibly short, simple 3-word directions like, breathe with me.
Because reducing that cognitive load allows the patient's autonomic nervous system a chance to actually reset.
Right. And if we connect this to the bigger picture, just consider how broadly this applies outside of a psychiatric unit.
Oh, totally.
Picture a parent standing in a pediatric intensive care unit, or a patient sitting completely alone waiting for a biopsy result. They are very likely experiencing that severe physiological cascade, recognizing that their cognitive bandwidth has shifted, that they literally lack the physiological capacity to process complex medical language in that moment. That has immediate consequences for patient safety and, honestly, just providing basic human compassion.
Yeah, managing the acute moment is all about recognizing that bandwidth. But treating the underlying disorder long-term and debating how these fears are acquired in the first place is where the medical literature gets fiercely complicated.
It really does.
Yeah.
Because the origin of specific phobias and anxieties fundamentally shapes how we actually attempt to treat them.
Right.
Back in 1920, John Watson and Rosalind Rayner conducted the famous Little Albert experiment.
Oh, the baby and the rat.
Yes. They introduced a 9-month-old infant to a neutral stimulus, a white rat. But every time the infant reached for the rat, the researchers struck a steel bar with a hammer right behind him, creating this sudden, terrifying noise.
Right, so the infant became conditioned to associate the neutral rat with the terrifying noise. But the most revealing part of that experiment was the generalization, wasn't it?
Exactly.
The infant didn't just fear the specific white rat anymore. The learned fear generalized to other furry objects, like rabbits, dogs, and even a fur coat.
Yeah, and that experiment proved a monumental concept in behavioral psychology. Phobias can be acquired through simple classical conditioning. They don't necessarily stem from deeply buried, unconscious Freudian conflicts.
There's a huge shift.
A massive shift, because if a fear can be systematically learned through environmental conditioning, well, it stands to reason that it can be systematically unlearned.
Which directly laid the groundwork for Joseph Wolp's introduction of systematic desensitization in 1958, right? Which is basically the ancestor of modern exposure therapy.
Exactly. You gradually expose the patient to the triggering stimulus in a safe, highly controlled environment, slowly breaking that conditioned neurological response.
Now, exposure therapy is highly effective, but it requires months of sustained, really uncomfortable psychological work. And when a patient is suffering from acute, debilitating panic in the present moment, they understandably seek a much faster intervention.
Of course they do.
And here's where it gets really interesting. Biologically, the medical field attempted to solve that urgency through the widespread introduction of benzodiazepines. Ah, yes. Drugs like Valium became culturally ubiquitous from the 1970s through the 1990s, and they were prescribed constantly because, mechanistically, they work incredibly fast.
They do work fast. Benzodiazepines bind to those GABA receptors we discussed earlier. They artificially enhance the brain's braking system, shutting down the excessive neuronal firing and halting the anxiety rapidly. But the clinical field learned a severe, painful lesson regarding the difference between acute symptom suppression and actual sustainable treatment.
Right, because that fast relief comes with a really aggressive biological cost. Benzodiazepines carry a massive risk of physical dependence, tolerance building, and just brutal physiological withdrawal if stopped abruptly.
The resulting public health crisis from that dependence forced a massive shift in prescribing guidelines.
Which is why SSRIs are basically first line now.
It's exactly. Today, SSRIs and SNRIs, selective serotonin and norepinephrine reuptake inhibitors, are the first-line pharmacological treatment for sustained anxiety management. These medications take several weeks to build up efficacy in the system, but they focus on long-term neuroplasticity rather than just an immediate chemical shutdown.
So to use an analogy, a benzo is basically a fire extinguisher. It is highly effective at putting out a sudden, dangerous flare-up in the kitchen, but you cannot use a fire extinguisher to prevent fires permanently.
Right.
An SSRI is more like installing a building-wide sprinkler system. It takes much longer to install and calibrate, but it provides a safer, continuous baseline of protection.
That's a great way to think about it. The transition from rapid suppression to long-term management really highlights how treatment evolves. But beyond just the pharmacology, psychiatry is currently grappling with something even bigger.
Which is
How culture fundamentally rewires the brain to manifest anxiety in completely different ways. The DSM is a Western diagnostic manual, and it does not represent a universal template for the human condition.
That is so true, and our sources emphasize this cultural variance heavily. The DSM-5 actually had to incorporate a cultural concepts of distress section just to account for presentations that fall outside Western biological assumptions.
Right.
Like, for example, among certain Latino populations, there is a recognized presentation known as ataque de nervios.
Yes. Attack de nervios often presents with intense screaming, trembling, and a profound sense of losing control. And it's typically triggered directly by acute family conflict or grief. So the anxiety manifests through this really intense, externalized somatic and emotional expression.
Okay, wow. And then you contrast that with something like Taijin Kyofusho in Japan, which reveals how societal structure dictates the specific target of the fear.
Right.
Because in Western individualistic cultures, social anxiety disorder is generally characterized by an intense fear of embarrassing yourself. The anxiety is directed inward at your own potential humiliation.
But Japan operates heavily on an interdependent self-control where social harmony is deeply prioritized.
Right.
Consequently, Taijin Kyofusho centers on an intense fear of offending or embarrassing other people through your own perceived physical or social flaws. The underlying biological arousal is the same, but the culture provides the architectural blueprint for how the fear is actually experienced.
But if culture shapes the symptoms that much, it naturally begs a massive question about how we define a disorder at all.
It definitely does.
Alan Francis, the psychiatrist who literally chaired the task force for the DSM-IV, wrote a deeply critical book about this called Saving Normal. He basically argued that the current diagnostic thresholds are far too loose.
Yes, his critiques are very well known.
Like, if you look at generalized anxiety disorder, the baseline criteria require excessive worry about multiple domains for 6 months, accompanied by mild physical symptoms like fatigue or muscle tension. But aren't we just describing modern life? Like, with economic inflation, continuous global news cycles, and the pressure of modern employment, how does psychiatry avoid over-medicalizing just being a normal, stressed-out human being?
It's a really valid pushback. The clinical defense against over-medicalization relies heavily on two very specific criteria written into the DSM: proportion and impairment.
Okay, proportion and impairment.
Right. To qualify as a pathological disorder, the biological anxiety response must be genuinely out of proportion to the actual objective threat. And even more importantly, it must cause clinically significant distress or functional impairment.
So impairment is the absolute dividing line.
Exactly.
Feeling nervous about paying your mortgage is a standard human trait. But being so consumed by that worry that you suffer from insomnia for 6 months, lose the ability to concentrate at your job, and entirely isolate yourself from your family, that is functional impairment. The system is no longer functioning.
Right. When the biological response actually prevents the organism from executing the necessary functions of daily life, that is when it crosses the threshold into pathology.
So what does this all mean when we look at the full picture? We trace the evolution from William Cullen's vague label of neurosis in 1769 through Freud's early categorization directly to Donald Klein, proving with impairment that sudden panic and chronic worry actually run on entirely distinct biological circuits.
And we established the critical baseline difference, right? Fear is the biological reaction to an imminent threat in the present moment, while anxiety is the anticipatory dread regarding a potential threat in the future.
Yeah, and we mapped out that physiological storm, the hyperreactive amygdala triggering the HPA axis, the locus coeruleus flooding the body with norepinephrine, and the failure of GABA to just apply the brakes. We demonstrated that this measurable physical reality is exactly why triage nurses are required to run objective cardiac tests to rule out a myocardial infarction before ever assuming a patient is just having a panic attack.
We also explored the practical bedside application through Peplaw's 4 levels of anxiety, understanding that when an individual escalates from mild anxiety into severe anxiety, their cognitive bandwidth just collapses.
It's just gone.
Exactly. The clinical response must shift away from education and problem solving, prioritizing environmental safety and simplified communication just to let the nervous system reset.
And honestly, you don't need to be wearing scrubs in an emergency room to apply that framework.
No.
Assessing someone's capacity before demanding comprehension is a profound tool for basic human connection.
It really is.
If you are navigating a conflict with a colleague or trying to comfort a partner and you recognize the physical markers that they have crossed into severe anxiety, you know their bandwidth is gone. Trying to force complex logic or problem solving onto them in that moment is like trying to push a massive data download through a broken connection. You just need to be present, lower the temperature of the room, and provide a safe baseline.
The biology dictates the intervention.
It really does. But before we wrap up this deep dive, I want to leave you with a final thought to ponder that builds on everything we've just unpacked about diagnosis and culture. We discussed how the modern psychiatric definition of an anxiety disorder fundamentally relies on the concept of proportion, the idea that the fear must be excessive relative to the actual danger.
Right, and the concept of functional impairment relies on a relatively stable understanding of what actually constitutes normal environmental stress.
But if the baseline actual danger of the world we inhabit continues to rise, driven by ecological instability, relentless economic pressures, and the constant digital influx of global crises, how will those diagnostic checklists have to evolve?
That's a huge question.
Right. If the environment itself becomes objectively more volatile and objectively more terrifying, does the definition of a disorder fundamentally change? Perhaps that diagnostic landscape is destined to become even murkier. Something to think about the next time you feel your pulse quicken while checking the morning news. Thank you so much for joining us for this deep dive. We'll catch you on the next one.